Good evening, and thank you for joining us at this virtual community lecture focusing on heart health. I'm Jane Neary, Executive Director of Cardiovascular and Perioperative Services at Providence Little Company of Mary. We are joined by cardiologist Dr. Rishi Kaushal and cardiac surgeon Dr. Matthew Powers. Before we get started, I wanted to let everyone know that this is an hour-long presentation and we will have plenty of time for questions at the end of the presentation. Please use the Q&A box to type any questions you have throughout the event, and we will do our best to get to each question at the end of the presentations. We will not be opening it up for attendees to speak on this webinar. Before I introduce our first speaker for the evening, I wanted to share a little bit about the partnership between Providence Little Company of Mary and Keck Medicine of USC. Through our partnership, our skilled physicians and surgeons offer the South Bay community the highest level of expert care and the latest in academic research. From diagnostic procedures to minimally invasive valve and open heart surgery, our patients can seek complex care locally instead of traveling beyond the South Bay. We also have 4 highly skilled cardiovascular surgeons from UST that operate at Providence Little Company of Mary Medical Center, Torrance, alongside cardiologists like Dr. Kaushal. We are also very proud to offer affordable and convenient heart screenings to our community. Many people experience no symptoms before having a heart attack or stroke, but a series of simple tests by heart experts can identify problems before symptoms develop and help prevent issues down the road. We urge you to have the advanced healthy heart screening if you're age 35 or older and have any heart risk factors. For more information, please go to providence.org/heart screening, and it'll also be featured in the chat box later. Lastly, I want our attendees to know that the information provided during this program is for educational purposes only. You should always consult your healthcare provider if you have any questions regarding a medical condition or treatment. Now, it is my pleasure to introduce Dr. Rishi Kaushal. Dr. Rishi Kaushal attended medical school at the UCLA David Geffen School of Medicine and went on to complete his internship, residency, and fellowship in cardiovascular disease and interventions at Harbor UCLA Medical Center. Multilingual in Spanish, Hindi, and Punjabi, Dr. Kaushal is excited to serve the diverse community residing in his native Los Angeles area. Dr. Kaushal is the Medical Director of Cardiology at Providence Little Company of Mary Medical Center, Torrance, and a Providence Medical Associates cardiologist. He understands the wide-reaching effects that cardiovascular conditions has on patients and their family. And his motivation and passion for practicing medicine is predicated on providing unparalleled patient care to each individual in their unique situation. He believes strongly in patient education and having each patient play an active role in his or her management of care. In his free time, Dr. Kaushal enjoys spending time with his family, music of all varieties, and playing basketball. Let's welcome Dr. Rishi Kaushal.
Thanks for that introduction, Jane. Can you hear me?
We can.
Okay, great, thanks. Free time is a funny term. Not much of that recently, but again, thanks for that introduction. Really happy to be here with everyone tonight. Ecstatic about the fantastic turnout tonight, and I think it's obviously a very important topic. And taking the time out of everyone's busy days to educate yourselves, whether it's truly preventing heart disease or whether you have heart disease and want to learn more about things to do to prevent progression of disease. Education, again, is probably the most important step that you can take. So again, thanks for being with us. I have a lot of ground to cover in a short 25 minutes. I'm going to start the presentation tonight by giving an overview of heart disease, what that means, signs, symptoms, risk factors, and how to prevent heart disease. And Dr. Powers is going to kick it off after that with some pretty exciting news about how we treat heart disease and advanced therapies for that. So let's jump right into it. So what is heart disease? It's a pretty broad term. It's an encompassing term. Refers to many different types of heart disease. Coronary artery disease, we're going to focus mostly on tonight. That's the most common type of heart disease in the United States. That's really what leads to heart attacks. Signs and symptoms of disease, we're going to move into risk factors and again, some prevention strategies, which is going to be very important. So what is heart disease? Again, it's a broad encompassing term. We're going to spend most of our time talking about coronary artery disease. congestive heart failure, arrhythmia, and valve disease. So those are the 4 topics we're really going to spend some time on tonight. Other terms that also are incorporated in heart disease, but we're not going to really talk too much about tonight, is cerebrovascular disease or stroke. Very similar underlying process for most of these types of heart disease, especially with coronary artery disease and stroke, aortic aneurysm or dissection, pulmonary hypertension, rheumatic heart disease, and congenital heart disease. So let's jump right into it. So the good about our treatment of heart disease is that we've made a lot of headway. In the last 50 years, actually, the incidence of heart disease has steadily declined, as you can see in this graph, compared to cancer, which is fairly static. And we can owe that mostly to the benefits of emergency medical care and long-term or longitudinal care, and really advancements in what we can offer patients. So patients nowadays, when they come in with a heart attack, 50 years ago, bed rest was the treatment. We then had aspirate, and that was the treatment. In the last 20 to 30 years, really, our technology has advanced. So we can do coronary angiograms on patients who are coming in with heart attacks, and within minutes, we can open up the artery. So that's really reduced the risk of death with heart disease. But we have a long way to go. So heart disease still remains the #1 cause of death in the United States, second to, or cancer is second. And this is really interesting. No surprise, COVID-19 actually takes the 3rd spot. And this is data from 2020. So again, we've made a lot of headway, but still heart disease is the #1 cause of death in the US. Some more grim statistics about heart disease. Someone is dying of heart disease every 30 seconds. Almost 700,000 people in the US die from heart disease. That's 1 in 4 deaths. Nearly 50% of Americans have some form of heart disease, especially when you incorporate hypertension or blood pressure into the definition of heart disease. And 50% of patients who died suddenly from heart disease or coronary disease had no preceding symptoms. So this is really an important take-home point. So even in the absence of symptoms, you still can be at risk. So, one of the points I'm going to make tonight is really having regular contact with your healthcare provider, getting your labs checked, getting your blood pressure checked, having these conversations on a regular basis. The silver lining of all this is that 80% of heart disease cases can actually be prevented, and we'll spend some time about strategies to do that. So let's jump into coronary artery disease. Again, this is the most common form of heart disease in the United States. It's really a process termed atherosclerosis, which is an inflammatory process that allows cholesterol and plaque to form within the coronary arteries. The coronary arteries is the heart's own blood supply. And this eventually can lead to narrowed artery, which then can reduce blood flow, eventually causing a heart attack, symptoms of chest discomfort and chest pain, and weakening the heart muscle. So what is a heart attack? When does it happen? So if enough cholesterol plaque occurs within the artery, you're going to get a reduction of blood flow. When the reduction of blood flow is pronounced and extends over a certain period of time, that's going to start to injure heart muscle. And that's what a heart attack essentially is. The more time that passes as that injury occurs, the greater the damage is going to be to the heart. So really timing is of the essence. In cardiology, we say time is muscle, and that refers to heart muscle. So when patients have any questionable symptoms suggestive of a heart attack, you call 911. You don't mess around. This is an example of a coronary angiogram. So this is a procedure I referred to earlier. In the vast majority of patients, we're able to do this procedure through a wrist approach through the radial artery. So it's a minimally invasive approach. It allows us to directly visualize the coronary arteries, the arteries that supply the heart muscle with blood. And what the arrows are referring to here is a severe narrowing. So above and below, if you can see my mouse pointer, this is an example of a normal coronary artery. This is our catheter injecting a tint or a dye within the coronary artery. And this represents blood flow. So this really allows us to make the diagnosis of coronary disease. And right here, again, where the arrows are pointing, there's about an 80 to 90% plaque buildup, what we call a stenosis. And everything beyond that has restricted blood flow as a result. This is a static image. Obviously, when we're doing an angiogram, it's a real-time picture. So this patient presented with chest pain, actually had a heart attack. This was the pre, and then this is the post. So you can see quite a significant difference, limitation of blood flow here, and the limitation is essentially gone. And this is with the use of a coronary artery stent. So coronary artery stents have really revolutionized our approach to treating coronary artery disease. It's a small metal scaffold. It's a permanent implant that's placed within the coronary artery to help keep that artery open over time. And this is another example of a coronary artery stent. They're fairly small, so the diameter ranges from 2.5 to 5 millimeters, and it approximates the patient's anatomy. We size it according to the patient's anatomy. Now, the really important point here is that coronary artery disease is treatable. Stents, surgery, very good options, but really the underlying process of atherosclerosis continues. Some patients, after they have a heart attack, we place a stent. I show them the before and after pictures, and they say, well, okay, I'm good, I'm cured. I don't have coronary disease anymore. And that's absolutely not true. I don't like to use the term Band-Aid, but it almost is a Band-Aid in certain cases because, again, the underlying process of atherosclerosis is progressive and ongoing. And it's up to the patient to make those changes to control their risk factors to really limit the progression of that process. So let's talk about the signs and symptoms of a major heart attack, and they do differ slightly between men and women, and that's an important difference to note. So the classic typical symptoms we all hear about is chest pain and discomfort, the elephant sitting on our chest. That occurs sometimes, but not all the time. It's not as clear, sometimes more subtle. Sometimes it's a heartburn sensation. The radiation of the discomfort into the jaw, the neck, the shoulder, or the arm is very important. Shortness of breath can occur as well. Women more often will have atypical presentations of heart attacks. So when women are coming into the emergency room, they tend to less often complain of the typical chest pain symptoms. And it's very subtle. Sometimes they'll complain of feeling nauseated, having some vomiting, lightheaded, or just unusually tired over the last day or several weeks. And so we really have to cast a wide net and have a low threshold when it comes to women, because sometimes and often these signs are missed. So if any of these symptoms are present, you call 911. Again, time is muscle. The longer these symptoms occur, the more damage can occur to the heart muscle. Once damage occurs to the heart muscle, it's usually an irreversible damage, and you can't get that muscle back. So let's talk about coronary disease when it doesn't present as a heart attack, and that's often the case. So any of the above symptoms that occur with exercise or physical activity can signify underlying coronary disease. And again, those symptoms we just went over. And the key to this, really the hallmark feature, is a reproducible and consistent symptom when you're exercising. And exercise as a preventative strategy is very important, but also as a test, right? If you're exercising daily or every other day, you're running a mile, and at a half mile, you start to notice this chest discomfort, and it happens again and again, and it goes away with rest. That's a clue that something is going on. Compare that to a patient who's fairly sedentary, not exercising. They're more often going to present with a heart attack because they're not getting those early clues. And obviously, if any of these symptoms happen, if it's significant, you call 911 and definitely talk to your healthcare provider if you're having any of these. So we're going to switch gears here a little bit and talk about congestive heart failure. A lot of details, which we're not going to get into, but if we boil it down and get into the basics, it's basically referring to an inability of the heart to produce sufficient blood flow to keep up with the demands of the body. So the two basic forms of heart failure are systolic, and we'll start there. Systolic heart failure refers to a weakening of the heart muscle, an inability to pump effectively. So the heart can't pump well enough when we refer to systolic heart failure. And a number to keep in mind, excuse me, and the phrase to keep in mind is something that we refer to as an ejection fraction. So this refers to the volume of blood that's being pumped forward with every beat of the heart. 55% and above is normal. Not 100%, but 50%. Anything below that signifies that the heart muscle is weakened for some underlying reason. When that weakening occurs, you're getting an inefficient forward amount of blood flow and also a congestion of blood flow back into the lungs and into the lower extremities. And that's what really causes the symptoms, which we'll talk about in a second. The second form of congestive heart failure is called diastolic heart failure. It's actually a fairly common form of heart failure. Patients with diastolic heart failure have nice, strong hearts. The contraction is good, but the muscle becomes stiffened and thick over time. So the relaxation is actually impaired, and the relaxation takes time. And that's really important because your heart has to contract and it has to relax to fill with blood to allow that process to occur. So if your heart's taking an extra amount of time to relax because it's thickened and it's stiff, the same process in terms of congestion is going to occur and the same type of symptoms can occur. So diastolic heart failure can occur due to underlying comorbidities such as hypertension, diabetes, obesity, whereas systolic heart failure usually occurs due to underlying coronary disease, prior heart attacks, silent heart attacks, where you get weakening of the heart muscle wall over time. High blood pressure, prior alcohol or active alcohol or drug abuse can cause that as well. Familial or genetic conditions exist where this can happen, and unusually prior heart infections can cause systolic heart failure. So what are some heart failure symptoms and signs? Shortness of breath and cough, typically with exertion or some form of activity. Really important hallmark of heart failure is when patients are trying to lay flat, these symptoms tend to occur more commonly in terms of the shortness of breath and cough. And if you sit up, you feel an improvement. So sometimes patients start saying, you know, I'm sleeping with 2 or 3 or 4 pillows because I just can't lay flat anymore because I can't breathe well. Swelling of the feet and ankles, weight gain, which is a reflection of fluid retention from that weakened heart muscle, and tiredness or fatigue. We're going to, again, switch gears here. This is kind of the third topic of heart disease that we're going to talk about tonight. And this is arrhythmia or abnormal heart rhythm. Very, very common. I'd say the vast majority of us actually experience an arrhythmia from time to time. And it's really a wide spectrum of disease, with many being benign and some not being so benign. Symptoms of abnormal heart rhythms usually are palpitations. Sometimes patients describe a fish flopping in their chest, dizziness or feeling faint, loss of consciousness. Obviously, those are high risk features that we definitely want to know about. Fatigue, feeling of anxiety or excessive sweating. And one abnormal heart rhythm that everyone should know about is atrial fibrillation. So let's talk briefly about that. So the electrical pathway of the heart, it's kind of a self-contained pacemaker system, very complex, very intricate. And with atrial fibrillation, basically you get this impulse, this overwhelming impulse of disorganized signals originating in the atria, which is the top heart chamber. Those disorganized signals are bombarding the lower chambers of the heart to beat irregularly and at a fast rate. What happens as a consequence is that, again, you get an irregular and fast heartbeat, and the top chambers, since they're not contracting nice and symmetrically, they start to wiggle, they start to fibrillate. And that creates a stagnation of blood flow, which can predispose a patient to forming a blood clot, which then can cause a stroke. So that's one of the main consequences of having atrial fibrillation, is that it can increase your risk of having a stroke. Often patients will have symptoms. Sometimes patients will have no symptoms whatsoever. And so again, just making that regular contact with your healthcare provider, checking your blood pressure, sometimes that can clue you into an irregular heart rate or heartbeat. When your healthcare provider takes a listen to your heart, we can sometimes notice it that way. If we're doing EKGs routinely, we can notice it that way as well. So again, just stressing the importance of having regular care. And you know, often arrhythmias are not so benign. This is a very malignant arrhythmia, which is not compatible with life. This is a ventricular fibrillation, and this is an example of something that will give you cardiac arrest. So if you're having any of these symptoms, we should definitely know about it. A brief word about pacemakers. So if your heart rhythm becomes slow for a multitude of reasons, age being a risk factor, a pacemaker is a fairly straightforward minor surgical procedure that can be corrective, and this is fairly common. And then finally, we're going to talk very briefly about valve disease and just some basic anatomy. There's 4 heart valves, 2 on each side of the heart, the right side and the left side. And the 2 basic forms of valve disease refer to stenosis, which is a restriction of the opening of the heart valve, and regurgitation, which is when the heart valve is closing, it's not creating a nice tight seal, and some of the blood is being leaked back into the chamber that it just emptied from. So the forward efficiency of the heart becomes impaired with either of these valve issues. Symptoms very similar to other forms of heart disease: chest discomfort, shortness of breath, typically with some form of physical activity, fatigue, or passing out. This is an example of an aortic valve, which is composed of 3 very thin leaflets. This is a normal valve opening, so it opens and has a nice orifice that allows blood to be ejected from the heart to the rest of the body. When it closes, it creates a nice tight seal. So stenosis, usually a function of calcification, scar tissue, which then creates a restriction of that opening, and then regurgitation, the same process can prevent those leaflets from closing. Okay, so let's switch gears here. We're going to talk about risk factors for heart disease. And, risk factors we can specify into each type of category for heart disease, but for the purpose of this talk, this is going to be more of an all-encompassing risk factor discussion, which does apply to most features of heart disease or most individual diagnoses of heart disease. So this graph represents really the incidence or prevalence, I should say, of risk factors among Americans, obesity being at the top of the list, a sedentary lifestyle, high blood pressure, smoking, cholesterol, and diabetes. And when we talk about risk factors, it's important to understand what is modifiable, what can you adjust through lifestyle modification, through medication, and what's not able to be affected. So modifiable, mostly influenced by our lifestyle choices, being overweight or obese, smoking, eating a diet high in fat or sugar, sedentary lifestyle, high blood pressure, high bad cholesterol. Let me just see how I'm doing on time here, and high blood sugar. So even if you're controlling those modifiable risk factors, and I'll go back and show that screen again, even if you're doing a really good job at controlling these, there are non-modifiable risk factors which you have no influence of. And so you can still be at risk of heart disease, even if you're following all the rules. And these non-modifiable risk factors include a family history of early heart disease, simply age. Typically, we say age over 55 puts you at increased risk of having heart disease, and a history of preeclampsia during pregnancy. So what can we do to strategize and to modify this risk, reduce your risk of having heart disease? And the American Heart Association has really put together a very strong and user-friendly campaign on their website that I highly encourage everyone to do. And they have some resources at the end of the talk to point you in the right direction for internet sources. And they've come up with a 7-step strategy. And I've included one step. And the first step is really to be aware of your individual risk factors, know your risk factors. And that again requires, routine medical contact, getting your blood pressure checked, getting your EKG, getting your labs checked. What's your blood sugar? What's your cholesterol doing? And so we'll go pretty briefly through these risk factors just in the interest of time. So again, know your risk factors. If you're between the age of 40 to 75, it's a high recommendation that you undergo a 10-year atherosclerotic cardiovascular disease estimation. And it's very simple for us practitioners to do. We need some basic labs and just some basic clinical information. And this can help to stratify where you are in terms of your 10-year cardiovascular risk, low, intermediate, and high. Based on that, we can formulate an individual plan for you in terms of what lifestyle modifications do you need? Do you need medications? Would you benefit from a statin? So very specific questions can be answered with just a very simple visit. Let's move on to a heart healthy diet. This is a topic, a 2-hour discussion in and of itself, but just some very brief high level points here. So there's a lot of different diets out there. The keto diet has a lot of recent press, and I probably get about 5 questions a day about a keto diet. And I'll just say, it's not studied long-term longitudinally in a cardiology aspect. And so we really don't know what the long-term consequences are. It can be effective at immediate weight loss. But personally to me, in a lot of the cardiology community, it just doesn't make sense in terms of the long-term effects that it's going to have, and probably does have some adverse consequences in terms of your cardiac risk. So what we tend to recommend is a diet high in vegetables, fruits, unsaturated fats versus saturated fats. On the next slide, we'll go over that. Minimize the animal sources of protein, but if you do consume meat, it's going to be, again, meat, less saturated fat forward. So that's going to be more of the fish, more of the lean meats, including chicken, poultry. Limit your refined sugar intake. This is really important because it can actually affect your cholesterol as well. So sweetened drinks, anything that tastes good, essentially. No, anything that baked goods, chocolates, candies. Those are really, really important. And we'll talk about different types of oils to avoid in the next slide. So replace your saturated fats in general with unsaturated fats, okay? So what is saturated fat mostly in? It's mostly in meat products, typically red meat. Despite the genius marketing campaign, pork is actually red meat and not white meat. There's leaner cuts, of course, but in general, any type of red meat is going to have higher saturated fat content than its counterpart in white meat. Dairy such as ice cream, milk, cheese, butter, and then coconut oil, palm kernel oil. Those tropical oils tend to have more saturated fats, so avoid those. Unsaturated fats, so these are healthy fats: olive, peanut, soybeans, flaxseed, avocados, certain types of nuts, and fish. And fish are also a good source of omega-3, which we know can help to minimize your cardiac risk over time. This is an example, and there's many, many different types of diets, and these are probably the three most well-studied in the cardiology community, and that's the DASH diet, the Mediterranean diet, and a vegetarian diet. So let's talk about activity level, right? And we say, you know, don't be sedentary, but what does that mean? So our general recommendation for most adults is that you should be getting either 75 minutes of vigorous aerobic activity a week or 150 minutes of moderate aerobic activity. What does that mean? So we've broken it down. What is moderate? What is vigorous? So moderate really means brisk walking, biking, active recreational swimming, something where you're working up a sweat, something where you're huffing and puffing, but can still complete or form sentences. Vigorous activity, you're probably not going to want to talk to your partner or counterpart when you're doing these types of activities. And that's really jogging, running, biking, singles tennis, for example, swimming laps. So 150 minutes of moderate exercise a week, 75 minutes of vigorous activity. And this slide, I love, the motivation's there, but simple steps every day. Take the stairs, right? Take the stairs instead of the elevator. Park a little further. So there's things that every one of us can do, despite our mobility or functional capacities. There's things that we can do to really push the limits. Manage your cholesterol. Again, know your numbers, right? See your doctor, get your cholesterol checked regularly. Aim to increase your HDL, which is your good cholesterol. That's done mostly through exercise. Smoking, refined, simple sugars can reduce your HDL, and you want to really optimize that HDL. Lower your LDL, which is your bad cholesterol. We talked about this in terms of reducing saturated fats, exercising, and again, your healthcare provider can really determine whether you can benefit from a statin or not. Manage your blood sugar if you're a diabetic or a pre-diabetic. The only way for you to know this is, again, having regular medical contact. And if you are in that category, really understand, track, and manage your blood sugar levels. And sorry, I'm running through this pretty quick just in the interest of time. I don't want to take away from Dr. Powers' presentation. Manage your weight. A body mass index is really the marker that we use to define weight, and a healthy weight is defined as less than 25. And this is most often done through diet, exercise. It's not easy. We struggle with this. I'd say 40% of my office visits are consumed by conversations about how to lose weight. And again, it's really just diet, exercise, calories in versus calories out. And there's a lot of resources out there through medical providers that we can offer. And more often, we've actually been even recommending bariatric surgery for patients who are unable to lose weight on their own. And we actually now have medically supervised non-surgical weight loss options as well, which is a very, very good thing for our patients. Manage your blood pressure. Normal blood pressure defined as less than 120/80. If you're taking blood pressure medications, if you have a previous diagnosis of high blood pressure, your goal is actually less than 130/80. Exercise, limit your salt, less than 2 grams a day. And so I say start looking at nutrition facts, get an understanding of how much salt you're consuming. Anything packaged, anything from restaurant, fast food, obviously is going to have more salt. So be aware of that. And smoking, a lot of patients don't recognize that can have an immediate impact to your blood pressure. So every time you smoke, you vape, any form of tobacco, the nicotine can actually temporarily raise your blood pressure. And sleep is very, very important. It's under-recognized. A minimum of 6 hours. Oftentimes patients come in with very high blood pressures when they've previously been very well controlled. I ask them about their sleep and they say they haven't been sleeping well for the past week, and that correlates with elevated blood pressures. Here's just a graph of what different categories of blood pressure are. And very, very importantly, smoking, right? Smoking is the most preventable cause of death in the United States. It's linked to 1/3 of heart disease deaths. And patients say, well, the damage is already done. I'm just going to continue smoking, and that's not true. After quitting, you can actually start to limit your risk. You can modify your risk. Within a year of quitting smoking, your heart disease risk goes down by about 50%, and this is well established. This is actually very well studied. There's so many different contents and chemicals within smoke of tobacco, nicotine, that just creates havoc on your cardiovascular system. So 20 minutes after your last cigarette, your blood pressure can start to lower. Your heart attack risk falls within 8 hours after your last cigarette. And once patients stop smoking, your risk of heart disease can actually drop to not to normal, but if you had not smoked, and that happens over a longer period of time. So the damage is not necessarily done. There's still hope. And so smoking is very, very important. It's a challenge, but very important to address. And then here's some resources that I promised I would give to you guys. And I don't know if these slides are going to be available to our audience. If not, hopefully we can send these out to you. But again, the American Heart Association and the CDC have done really a wonderful job. It's a really user-friendly website, has a ton of resources that I highly encourage everyone to look into. So that's it for my talk. I think we're going to do questions at the end. Thank you so much for your time, Dr. Powers. I apologize if I went over time.
Thank you, Dr. Kaushal. Very informative. I'm sure that our audience is appreciative of all the information, very detailed and explained. Thank you. Now it's my pleasure to introduce Dr. Matthew Powers. Dr. Matthew Powers earned his Doctor of Medicine degree from the New York University School of Medicine, completed his cardiothoracic fellowship at the New York Presbyterian Hospital, Columbia University, New York, and his residency at the Keck School of Medicine of USC, LA, where he also was the Chief and Administrative Chief Resident of General Surgery. He's certified by the American Board of Thoracic Surgeons and the American Board of Surgery, and is a member of the American College of Surgeons, American Medical Association, the International Society of Heart-Lung Transplantation, and the American Heart Association. Dr. Powers specializes in the surgical treatment of adult heart disease, including heart failure, coronary revascularization, temporary ventricular assist device, aortic surgery, minimally invasive valve repair, and all the sophisticated surgeries and heart surgeries. His clinical interests and advanced fellowship training involve the treatment of complex diseases of the thoracic aorta and advanced valve repair techniques. Dr. Powers is currently the Medical Director of Cardiac Surgery at Providence Little Company of Mary Medical Center in Torrance, and an Assistant Professor of Clinical Surgery at the Keck School of Medicine. Please welcome Dr. Matthew Powers.
Thanks, Jane. Those are very kind words. I appreciate the introduction. Let me just pull up my screen here so we can share. Let's see if we can get the slideshow going. Great. Again, thank you, Jane, for the kind introduction. I'd also like to take a minute to thank our event organizers, Katie Kuhn, Andrew Wirtz, and our Chief Executive at Providence Little Company Mary, Gary Olney. Now, Dr. Kaushal is he's a tough act to follow, so I hope I can entertain the crowd. We will have plenty of time for questions after. My goal is to give a nice overview of the surgical options treatment for heart disease that we have available to you in the South Bay community. And just like Dr. Kaushal mentioned, prevention is key. But when intervention is required, you want to have access to the latest and safest technologies. And throughout this talk, you'll hear that collaboration is key in a lot of the treatments between our cardiologists and heart surgeons. So this partnership between Keck Medicine of USC and Providence Little Company Mary was initiated in 2019. And this goal was to provide access to an academic world where new processes and procedures are developed. We're looking to strengthen the reputation and quality of the hospital's heart program. And this partnership has allowed Providence patients access to a higher level of care without needing to leave the South Bay community. It allowed access to heart surgeons, of which we have 4 faculty from USC that are on staff here at Providence Little Company Mary. We have access to clinical trials for patients, easy access to new innovations and technology, and again, easy access to higher level of care should transport to a heart transplant center happen. And that's happened to us at the Little Company Mary. And our surgeons have with ease able to quickly and expedite care of these patients. Again, our goal is to provide the highest level of care in the South Bay without needing to leave to other centers. Now, my purpose is to give you a little brief overview of what our comprehensive cardiac surgery program looks like. And I'll go through some of our new technology and some of our surgeries that we can provide in a minimally invasive fashion, and some of them we perform with our cardiologists. So first, as Dr. Kaushal really eloquently illustrated, is the treatment of coronary artery disease. And the real hallmark of treating coronary artery disease is to use a collaborative model where our cardiologists and heart surgeons evaluate these patients and determine what's the best option for treatment. Dr. Kaushal showed us that prevention is key. There's also lifestyle, diet modifications, and optimizing medicines. But once you've had a heart attack or you're having symptoms or that heart muscle squeeze reduces, intervention's required. Otherwise, you're going to have a shorter life. And we want to spend more time with our families and have a better quality of life. And sometimes intervention allows us to bridge that. And coronary artery disease can be treated with stents, as Dr. Kaushal noted, and that's been a fantastic evolution in treatment of coronary artery disease. There are instances where surgical intervention is the optimal therapy. And at Little Company Mary, we offer this therapy with on-pump and off-pump coronary artery bypass grafting. And essentially what that means is we don't try to touch those blockages as was noted in our last talk, which was open with a balloon and stent. In fact, we leave those blockages alone, and we're able to reroute new blood flow using your own artery and veins to provide what's called a bypass to that blockage and provide the heart with enough blood flow that the heart muscle has preserved function, will give you a better quality of life and a longer life without repeat heart attack or need for another intervention. That's the goal with heart surgery. Now, we talked about heart failure in our last lecture, and Dr. Kaushal mentioned diastolic and systolic heart failures. And we've come a long way in terms of helping you bridge the gap. Now, treating the heart muscle is paramount, but when the heart fails, we do have devices that we're able to support the heart with. And these are small devices that we're able to utilize nowadays. You can see in the palm of the hand. These are small devices that we're able to insert either surgically or percutaneously through access of the arterial system in the groin or up underneath the collarbone. And these are called left ventricular assist devices. And if you've had a major heart attack or if you have heart failure where the heart isn't able to pump, these are miniature rotary devices that actually take over the entire workload of the heart. And the heart can relax and recover from its heart attack, or it can be used as a bridge for future therapies, such as a permanent implant of a ventricular assist device, which is a larger device that you can live with a battery pack, or a heart transplant. And some patients do eventually require heart transplant. The problem with that is that donors are limited, and our goal would be to bridge you to a recovery. And we have these technologies here at Little Company of Mary. They come in a small, medium, and large size, and we have all those options available if they're needed. Another fascinating intervention that we've been able to offer patients at Little Company Mary is treatment for end-stage heart failure or even lung failure. And this is called Ecmo. And Ecmo stands for extracorporeal membrane oxygenation. And in a simple overview, it's a pump that's able to take over the work of either the heart or the lungs, depending on how the machine is configured. And the picture shows a portable device at the bedside that's able to take over the work of the heart or the lungs if it fails. And this has been a remarkable piece of technology that's been utilized in the heart surgery field to help recover patients who are in duress. And you really want to be at a center that has these support devices. And at Little Company Mary, we're very proud to be able to have access to this technology. Now, COVID-19 presented quite a conundrum for physicians and surgeons. When the lungs fail, what do we do? Well, this machine can actually help take over the work of the lungs when all options for mechanical ventilation have been exhausted. And we've been very fortunate to have access to this technology at Little Company Mary and within our regional ministries to help provide access to the highest level of care possible. Now, we heard a little bit about arrhythmia surgery, and atrial fibrillation was touched upon. And atrial fibrillation is that uncoordinated movement of the chambers of the heart. And that doesn't provide for good efficiency for the heart, and you can feel quite lousy. But the main risk of having atrial fibrillation is that risk of having a clot form in your heart, and clots in the heart get ejected from the heart as the heart squeezes, and the first place clots go is to the brain. So the very high risk of having a stroke with atrial fibrillation and arrhythmias. Now, as surgeons, we have capabilities of providing treatment for atrial fibrillation. We have what's called the Cox-Maze procedure. And essentially that is an ablation of the upper chamber called the left atrium of the heart. Now, the back of the heart doesn't provide much contraction, but it sure causes a lot of problem. This is where most of these short circuits or re-entry circuits of atrial fibrillation are. Now, if we can form some scar in the back of the heart, we can prevent this atrial fibrillation and reduce the risk of stroke. And that's the whole goal, reducing the risk of stroke. And that's why many people are on blood thinners because of atrial fibrillation. It's really to help prevent stroke. Now, if we can cure or eliminate the atrial fibrillation, you can come off the blood thinners, and that would be a huge goal for many people, to stop taking blood thinners, avoid the easy bruising and risk of bleeding. Now, we talked a little bit earlier about collaboration, and we've been able to bring in some new technology that's a hybrid treatment for persistent or permanent atrial fibrillation with our electrophysiologists, who are cardiologists who are specialized in treating arrhythmias and electro activities of the heart. And as surgeons, we play a vital role in this. And as we look at progression of treatment of atrial fibrillation, we used to cut and sew the heart back together to try to prevent these re-entry circuits and form scar tissue to eliminate the atrial fibrillation. And slowly but surely, we've been able to minimize the approaches from an open heart procedure to a very small thoracoscopic or camera procedure in the side of the chest. And just recently, there's been newer technology that is called the Convergent Procedure, where we're able to make an incision that's smaller than 1 inch underneath the breastbone and perform what's called a epicardial ablation. And this is a catheter. It's called the EpiSense catheter, and it basically sucks onto the back of the heart and provides these ablations to the back of your heart to try to prevent these re-entry circuits and eliminate atrial fibrillation from the posterior wall of the left atrium. And that's important because that's a difficult area for our electrophysiologists to manage, which is why this subset of patients with persistent or permanent atrial fibrillation, they really had no good option for treatment in the past. And once this hybrid approach came out, it's really revolutionized options for treatment of patients with atrial fibrillation. And we've started the program here at Little Company Mary. We've already had excellent results eliminating atrial fibrillation in our patient that's come through. Just a brief view on the upper left, we can see the back of the heart is where those scar or black markings are. And we have a great view through that very small, less than 1 inch incision. And we do have nice monitors that show us the impedance or power to show we have a nice full thickness scarring that's formed in the back of the heart. And we see our results immediately. And this is a fantastic approach. Now, we do combine this with the hybrid treatment with our electrophysiologists. And again, collaboration is key for treatment. And we're able to map out our markings and allow our electrophysiologists to help complete the job and get the patients off blood thinners. And that's really the goal, to come off blood thinners, reduce your risk of stroke, and eliminate the atrial fibrillation. Now, when we talk about atrial fibrillation, I've been mentioning the stroke risk. And 90% of clots form in what's called the left atrial appendage. And this is a small area off the back chamber of the heart where blood clots tend to form. Now, that area of the heart doesn't form any functional part of the heart. It's analogous to the appendix of the colon. It doesn't serve any function of helping you digest, but boy, when it gets infected, it causes you a world of hurt. Now, this area in the heart, you can do without. In fact, most of us would do better off without it. And we do have some minimally invasive techniques to remove that. And what we see here is what's called an atrial clip, and that's essentially a large paper clip with a cloth banding around it that eliminates that appendage, and it reduces the risk of stroke. And that's our goal, is reducing risk of stroke. And this is available here at Little Company Mary. We do this with our open surgery procedures. We also do them with isolated thoracoscopic or minimally invasive procedures through the side of the chest. Again, here shows us a cartoon of how we access, and we use very small, less than ½ inch or ¼ inch incisions to put in a camera in our device, and we're able to see the heart and occlude this appendage using our video cameras within the chest. And most of these patients, it's an overnight procedure and you're home the next day. Really great option. The other collaboration we perform at Little Company Mary with our cardiologists and heart surgeons is valve replacement. And we're able to do this now with a transcatheter route. And that means just a small puncture in the groin artery. We're able to replace and position in a new heart valve. And Dr. Kaushal showed us earlier what aortic valve stenosis looked like when there is a restricted opening of the heart valve. Well, now we have a new technology where we don't even have to open the chest to replace your aortic valve. We're able to put a catheter and wire into the heart, and we use a balloon to redeploy a new valve right inside your heart, and the heart valve starts working right away. This has really revolutionized the treatment of aortic valve stenosis. Again, great collaborative program we have at Little Company of Mary. We also have options for the other treatments of valve disease, be it valve repair or replacement for the other valves Dr. Kaushal hinted at, the mitral valve and the aortic valve. So we don't need to make the big, large incisions anymore. What we do is we can make a 2-inch incision and repair the mitral valve from regurgitation or leaking of blood flow backwards. We're able to do all these complex repairs and really piece everything back together through these really small incisions. What does that mean as a patient? That means getting back to life quicker. It means getting back to driving, getting back to golf, tennis, life, much quicker, much faster recovery with the same quality results as we've done in the past with the big open operations. We're able to do this with very small incisions, and we use a little camera to allow us to have the best view possible. And this is available here at Little Company of Mary with help with our Keck USC surgeons. As a comprehensive program, we also offer aortic surgery is a passion of mine. We offer aortic root surgery, ascending, aorta and arch replacement, and we offer aortic dissection repair. And we've had excellent results with our program. And what the aorta is, it's the large tube of blood that leaves the heart. And if that tears or ruptures, it's life-saving surgery. Unfortunately, 50% of people don't make it to the hospital, but when you do, you want a surgeon who's able to fix and repair that really with perfection, give you the best chance for survival. And we do have this technology here. My partner, Dr. Cash, also performs what's called Tvr procedures, or stenting of the descending aorta if you have any tears or ruptures in that area. And that's some newer technology that's available here in the South Bay. Again, our hallmark is to not have you leave the South Bay to get the best quality of care. Well, that's all I've got for you. I think we're going to be opening up for questions with Dr. Kaushal, and I think Jane's going to help guide us through that next stage of our talk here today. I really appreciate the opportunity to speak with everyone, and happy to answer questions with Dr. Kaushal.
All right. Thank you very much, Dr. Powers. So before we begin our Q&A, and I encourage the audience to please use the Q&A box while we have Dr. Kaushal and Dr. Powers here live. We'd love to have your questions answered. Before we begin our Q&A, though, we have a few questions for you. If you could please answer the poll that you see appear on your screen and give us your honest feedback. We would certainly love to hear from you and provide more services or more topics that would interest you. All right, let's start. We have a question. We have one. Oh, what areas will you be expanding in and what are your funding needs? As we see this, Dr. Powers, Dr. Kaushal.
Great question. Funding needs we are in need. So that's an easy answer. But no, in terms of the other question, which was future directions, I think, we're currently in the process of expanding quite a few things, and Dr. Powers can probably speak more on behalf of the surgical program, but from the interventional cardiology side, which we do in parallel with surgery, is expanding our access to structural heart procedures, where we can put in small plugs in the left atrial appendage, as Dr. Powers mentioned, and minimally invasive techniques, a wider array of minimally invasive techniques to fix valve disease. Something called mitral clip, where the mitral valve, if it starts to regurgitate significantly and cause heart failure, if patients don't have a surgical options are still the best primary approach for patients with mitral valve disease. But if they are high risk, advanced age, where we don't feel like they would do well with surgery overall, there are minimally invasive techniques that don't require surgery to treat that, which are commercially available. And we're looking to expand to that program in the next 6 to 12 months. So things along those lines. And, we're always pushing the envelope in terms of surgical and minimally invasive options for coronary disease, for valve disease, for peripheral arterial disease. So again, I just would like to echo the comments that Dr. Powers made in terms of the comprehensiveness of this program and in our ability to treat everything. And in certain higher level cases where a patient does need heart transplant that we can't offer here, we have a backdoor entry into a world-renowned program at USC.
Yeah, I would echo some of that newer technology Dr. Kaushal has mentioned, and a lot of the treatments are leaning towards minimally invasive access. There are clinical trials in Europe underway for treating aneurysms of the aorta without having to open the chest, and there's new stent graft technologies that are being developed. And there are clinical trials at USC that we're collaborating with. So once we get good results from those, we're going to be able to have immediate access to that comprehensive and new technology here in the South Bay. So stay tuned. We're really excited about some of the new aortic technology that's coming out as well.
Thank you. We have another question. What is the best non-invasive procedure to identify heart disease? And what is your opinion of CAT scan, CT scan? And I'm not sure if this is a cardiothoracic scan or.
Yeah, so that's it's probably referring to a cardiac CTA or a coronary calcium score, which we actually use quite often in cardiology screening. And, for patients with known coronary artery disease, we tend to use it less often because we already know that you have coronary disease and there's other techniques to better get information. But I think it's integral in our approach to diagnosing coronary disease in the first place, and further risk stratifying. We always use this word, risk stratification. Where are you in that category? Are you low, intermediate, or high risk? And to answer your question, there's really not one best one. There's different tests which are more suitable and more appropriate for different patients. If you're in a low risk category or a low suspicion category, we tend to stay on the minimally invasive option. If you're a higher risk in terms of your comorbidities, that may involve a little bit more sophisticated testing. But you know, the CT technology has advanced tremendously over the last 10 years, and it's something that we do rely heavily upon.
Thank you, Dr. Kaushal. I have another question for Dr. Powers. How often does heart surgery actually result in AF?
Well, I think they're asking, does atrial fibrillation happen after heart surgery? That's pretty common,
Yeah.
actually. About a quarter of patients who undergo heart surgery have what's called paroxysmal or temporary atrial fibrillation. And the reality is, after 6 months, over 90% of those brief arrhythmias are completely gone. So atrial fibrillation does happen after heart surgery. It's easily treated with medicines, and nearly all of them go away if they're just associated with the heart surgery. Now, if you're asking, maybe the question was better phrased of how successful is the surgical treatment of atrial fibrillation? Across the board, it's about 70% effective. Now, we have, with this new Convergent procedure, getting upwards of 80 to 90% effectiveness in the hybrid approach to treating atrial fibrillation. So really a fascinating new technology to really offer patients the best opportunity to get rid of atrial fibrillation. I think you're muted, Jane, sorry.
Oh, thank you. Thank you, Dr. Powers. So there's a question here. Dr. K, as your patient, what should I do to be more aware of symptoms as they have not surfaced in the past? Are you typing your answer?
Yeah.
Okay, good. All right, that's fine. And so we can address another, or you want to answer that?
I'll address it for
yeah, sure.
Actually, I think that's a good question. Again, you know, exercise and just maintaining an active lifestyle is going to be really key. And there is a group of patients, there's a subset of patients who, despite high levels of activity, you still remain asymptomatic despite underlying coronary disease. And that's where our testing, our non-invasive testing comes into play. So we can, while you're on a treadmill, for example, or doing specific types of stress tests, we can assess blood flow to the heart muscle. And if you're not having symptoms, but your stress test comes back positive, for example, then we uncover the problem that way. But again, just an active lifestyle is really your best at uncovering symptoms. So as you exert yourself, your heart muscle demands more oxygen. And if there's a supply issue in terms of coronary disease, or even a valve issue or a congestive heart failure issue, that's when those symptoms are going to manifest the most. So again, activity is key.
Thank you. We have another question. We have lots of questions. That's great. Thank you for the questions. How long does an initial heart evaluation take, as it has been challenging to get my partner to do it, despite his risks? What wording would help me convince him to do it? Help her, him, her, whoever it is.
That says it all. Yeah, I'll take that one. You know, initial heart evaluation is fairly straightforward, and it's a series of questions that we go through in terms of assessing symptoms, lifestyles, and we review available lab results and see where you are in terms of cholesterol, your diabetic control, your blood sugar control, blood pressure, all the kind of the typical biometric data. So we can often really do that in a matter of 30 minutes in terms of a face-to-face visit. And then based on, again, what your risk level is, then we typically say, well, let's stratify you further with some form of stress testing based on the presence or absence of symptoms. And so we always want to get more information about your risk. And sometimes if a patient is asymptomatic but has extensive comorbidities or risk factors, but you're exercising and you're doing everything the way you should, often in those cases, I will get a coronary CT calcium score, which assesses one of two types of plaque. It's assessing hard plaque within the coronary arteries that may have built up over time. And it just gives us more information about your risk and how much more aggressive should we be at controlling that risk.
Thank you, Dr. Kaushal. And I think this is Dr. Powers. What is the percentage of success for stenotic aortic valve, bovine or mechanical replacement? Your thoughts?
Yeah, so there are two options for treating aortic valve stenosis in terms of valve replacement. The bovine, or this is the valve prosthetic or tissue valve, is one option. Mechanical is the other option. And there's been a big pendulum swing away from the mechanical valves. And that has really a two-pronged answer. One is it's always individualized to the patients. For patients really older than 60 years old, we strongly suggest the prosthetic valves. Now, the downside with the prosthetic valves is that they do wear out. And so they're not a forever valve. They do wear out over time, but with the advent of TAVR or the percutaneous therapy to replace them in 10, 15 years, that's a great option rather than having to redo the big open heart surgery. Whereas the mechanical valves, you have to be on blood thinners for the rest of your life, and that has risk of bleeding and stroke. And they tend to be used for the younger patients who can tolerate the blood thinners. But really, it's an individualized question nowadays, and it has to take very careful consideration. Age, activity, lifestyle, all that matters in valve selection. But with the advent of the newer percutaneous therapies, even for the mitral valve, we're going to be seeing more tissue valves because the valve-to-valve technology is getting better and better and better. So most people are leading away from the mechanical valves. I hope that answers some of your question.
I think it did to the to the best of our abilities, given the that we're pressed for time. So we'll answer a couple more questions, and if we don't get to your questions, we will reply and send our responses, of course, from our physicians. So they did say thank you, Dr. Powers. So it looks like you did answer the question. So is it bad to exercise once a day for an hour when the rest of the day I'm more sedentary? Is that a trick question?
It is kind of a tricky question.
It is.
No, I think that's fine. I mean, you know, if you're getting at least moderately intense exercise, then that's, you know, that's good. I mean, I think you can improve upon the remainder of the day. And, you know, it's like we say, sitting is the new smoking. So, you know, prolonged periods of inactivity are also important to note that is an increased health risk. And really, that's why we're seeing more of a push for, you know, standing desks and things like that. And especially with people working from home, I think this is an important point. One of the, you know, many kind of consequences of COVID, people are working from home. And what we've seen is kind of an increase across the board in terms of patients' weights and more sedentary lifestyles. A lot of patients I see are often working longer hours, you know, despite working at home. So I think just keeping that in mind, staying active, the fridge is right across the way, just having that motivation and discipline and standing up, walking around every so often, I think that's really important.
All right. And then one last question, and we'll get to the other questions. Heart screening information will definitely send you the information. We have your contact, those who are asking those questions. And the one that missed the first 10 minutes, the presentation will be sent to you. So we'll give you that information as well. But one last question here. What are your thoughts on Repatha and its use against heart disease?
Yeah, I'll take that one. I mean, it's really a game changer for the care of cardiovascular patients. There's still, you know, very specific indications and times that we use it. It's a fairly expensive medication, so insurance companies have kind of a tight grip on who they will pay for to get this medication. But it's one of the very few medications that's actually been proven in a subset of patients, not everyone, but in a subset of patients, to actually allow for plaque regression. So to the best of our knowledge, statins at certain doses help plaque stabilization, but they don't make the plaque go away. PCSK9 inhibitors like Repatha or Praluent can actually allow that to happen, where plaque actually can go away over time. So that's why I say it's a game changer. It's indicated for patients who can't achieve goal LDLs despite maximal statins, or have intolerances to statins, or have secondary events despite optimal LDL control. So it's playing a bigger role in cardiology.
Thank you, Dr. Kaushal. And thank you to all of you for taking the time to listen and ask questions. And a big thanks to Dr. Kaushal and Dr. Powers for taking the time to provide us with this valuable information. We will be sending the recording of the presentation to all the attendees for you to have. We will also be posting this on our Facebook page for everyone to be able to view and share. You can find us at Little Company of Mary South Bay on Facebook. For any additional information or to schedule a physician appointment, please call our Patient Engagement Center at 1-888-HEALING, HEALING. Thank you again and have a great rest of your evening.
Thank you.
Thank you.
Thanks, everyone.